Okay, well, I am absolutely delighted to welcome everybody to the second annual Gaspar Carrasquer lecture. And I could spend the entire hour talking about Dr. Carrasquer and then another hour talking about Dr. Aronoff, our speaker for today. However, since I'm actually very interested in what George has to say, I'll keep my comments brief. So for those of you who knew Dr. Carrasquer, you know that this was a man with an outsized presence because of what he did. He was a very humble individual. However, he was a man with many, many accomplishments. He was a consummate teacher and for decades taught a course in fluid and electrolytes for the medical students, taught very well on the wards as well. He was also a first-rate investigator. The subject of his investigations were ion transporters and pumps. He, in fact, some of the work that he did contributed towards our knowledge of the hydrogen ATPase, which, as you guys know, is the target of the PPI inhibitors now that are used so extensively for GERD and other diseases of the stomach. His first article that he published was in 1959, and the last one he published was in 2002. That is just an incredible career in investigation. And of course, last but not least, Gaspar was an absolutely wonderful clinician. Patients absolutely loved him. For years after he retired, people would come up to me and say, whatever happened to that nice gentleman with the white hair? I really liked him. And that, I think that characterized him. Everybody knew him as a gentleman who showed respect to everybody that he worked with, patients, colleagues, students, etc. We are indebted to the Carrasquer family for endowing this lectureship, and we have as our guests today his wife Carol and two of his sons, Alex and Richard, and his very good friend and colleague for many, many, many years. And thank you so much, all of you guys, for coming. Very much appreciated. Let's give them a hand for supporting our academic mission. Now, last year, we had an individual of international stature from this institution give the first Carrasquer lecture. That was Dr. John Klein. And this year, we have our second lecturer, who is also an individual of international renown, and that's Dr. George Aronoff. George is a Hoosier. All of his training in Indianapolis, and was wooed down here in 1987 by Joe Allegra to become the division chief for nephrology. He was quite young at the time and remained the division chief for 21 years, during which period of time he built this division in terms of its clinical program, its research program, and he garnered for this division many teaching awards, both for himself and for the division. I think everybody at the institution who knew George knew him as an absolutely consummate teacher. And he had really a way of being able to take very difficult concepts and boil them down to something that was not just understandable, but interesting and provocative. His interests have been in the pharmacology and pharmacokinetics and how that relates to kidney disease. He was one of the co-authors of a book that many of us walked around with for decades on drug dosing in kidney failure. He's also had a strong interest in looking at chronic kidney disease and what we can do to try to prevent the progression of chronic kidney disease. After George left the University of Louisville, he joined Renal Ventures as a chief medical officer, and when that was acquired by DaVita, he is now employed at DaVita as one of their vice chairs for clinical affairs. However, he has not disappeared from the Louisville scene and maintains a very, very close relationship and collaboration with Dr. Mike Breyer, Dr. Adam Govenda, and Dr. Chip Jacobs here for the work that they're doing on the modeling of drug therapy in kidney disease. So it is absolutely my great pleasure to welcome Dr. George Aronoff as the second annual Gaspar Carrasquer Lecturer.
Thank you, Eleanor. It's such a pleasure and a really heartfelt honor to be here to give the Carrasquer Lecture this year. Gaspar was here on the faculty when I joined the faculty, and I could, as all of us, I could tell many Dr. Carrasquer stories, but I won't. The one thing that I will mention is that the entire time that I was division chief, Gaspar was always available, eager, and willing to do whatever it took to teach students better the medical school and the University of Louisville. And when Gaspar retired, he was the longest standing member of the faculty at the University of Louisville, not just the School of Medicine, but the University of Louisville. And if you think about literally the thousands of students that he impacted. And so what an honor and a privilege to give this named lecture in his honor. I have to say that when I left the university, I had given grand rounds that year. And as I was leaving, I wistfully thought, this will be the last time that I give grand rounds. Thank you for making me wrong. Again, a pleasure and an honor. I'm going to start out real briefly with a very brief story, a case. An older, retired Lebanese-American physician, a retired ophthalmologist, known to have chronic kidney disease, had an intercurrent illness, went into the hospital, was found then to have end-stage kidney disease. He went on dialysis for a short time, but the happy ending of the story is that he received a kidney transplant and remains healthy with a kidney transplant. That is not the usual story, but it is one that has a happy ending, and I'll come back to it later this morning. This is my disclosure slide. I'm now an employee of DaVita and work with the dialysis industry. So our educational objectives for this morning, I'm going to talk about strategies for slowing the progression of chronic kidney disease, particularly focusing on our ability to impact hypertension, diabetes, and cholesterol, which are factors that hasten, when they're not controlled, hasten the progression of chronic kidney disease towards end-stage kidney disease. And then for those patients for whom end-stage kidney disease is inevitable, we need to discuss some planning for future renal replacement therapy, including the choice of modality for that therapy, dialysis-related access, the treatment of comorbidities like anemia, and their nutrition. Now, I will point out that the time for us to address hypertension, diabetes, and cholesterol to slow down the progression of chronic kidney disease is as early in the process as possible, because we know that once patients develop end-stage kidney disease, managing their hypertension, their diabetes, and their cholesterol has much less of an impact on their eventual outcomes. Now, almost 30 years ago, the National Kidney Foundation established this schema for estimating kidney function based on glomerular filtration rate. And prior to that time, we did not have a precise definition of chronic kidney disease. And so it meant to whoever was talking, it meant different things. So patients that have a normal GFR but have proteinuria or some structural kidney damage, that would be stage 1. As GFR declines, the stages increase from stage 2, stage 3, stage 4, stage 5. And we have used this schema for our planning and our approach to patients with chronic kidney disease for the last 25 to 30 years. I wanted to show you some statistics, some data. Chronic kidney disease is much more common in the United States than most people believe. There are currently almost 40 million Americans that have chronic kidney disease as by the definition that I just showed you. 15%, that represents 15% of the U.S. adult population. 33% of diabetics have chronic kidney disease, and half of the adults between the ages of 30 and 65 are expected to develop some form of chronic kidney disease during their lifetime. But 90% of our patients who have chronic kidney disease are not aware that they have chronic kidney disease, and so they may not be aware of the importance of managing the comorbidities that I articulated earlier. There are 750,000 Americans that have end-stage kidney disease that requires renal replacement therapy, either by dialysis or transplantation. We have 100,000 incident new patients each year requiring going on dialysis or getting a transplant. And we have about 100,000 awaiting kidney transplants each year. And these are data that I accessed from the CDC website last week, just to give you the most recent data. The causes of chronic kidney disease have not changed. And although, again, I accessed these data this month, 2/3 of patients with chronic kidney disease, whether they're on dialysis or whether they are not yet on dialysis, 2/3 of them either have diabetes, almost 40%, or 1/4 of them have high blood pressure as the main cause of their chronic kidney disease. All of the other diseases of the kidneys make up only about 1/3 of the patients that have end-stage kidney disease. Now, I apologize for this picture. It was taken from the back of the room for obvious reasons, and it was taken with a very old iPhone. But Wednesday, July the 10th of this year was literally a red letter day for kidney health in the United States. Because if you can see the president holding up the executive order that articulated these 6 points of emphasis going forward. The president's executive order instructs us to develop processes to prevent kidney disease and kidney failure whenever possible, to increase patient choice, and by that he's referring to home therapies and transplantation, and increasing access to transplant, to establish an awareness of kidney disease initiative for these millions of patients that have chronic kidney disease, and to encourage technical innovation in providing renal replacement therapy for those patients who develop end-stage kidney disease, and to establish new payment models to pay for the kind of chronic care that patients with end-stage kidney disease require. Now, although the president is sort of in the middle of this picture, he's really not the most important person in this picture. The most important person in this picture is Secretary Azar, Alex Azar, Secretary of HHS. It was Secretary Azar's father, who I described at the beginning. He's the retired ophthalmologist who developed end-stage kidney disease, was on dialysis for a time, and then was successfully transplanted. And we've been working with Secretary Azar since he was appointed, and with his predecessor, to establish this executive order, which we think will really help to emphasize the importance of kidney health in America. Now, I would like to think that the reason that the government is so interested in chronic kidney disease is because of the millions of patients that are affected by chronic kidney disease. But the fact of the matter is, it's these payment models that the government is so interested in because of the billions of dollars in economic burden that chronic kidney disease causes in the United States. Now, when you see these numbers, and again, these are numbers that Secretary Azar made in remarks to the National Kidney Foundation in March of this year, I included on this slide all the zeros, because when you just write 113 billion and you write out the word billion, you lose the perspective of how many zeros there are in the economic burden. $113 billion in Medicare spending for patients with chronic kidney disease, 79 billion for CKD, and 34 billion of that for end-stage kidney disease. That represents 20% of all Medicare funding in the United States. And all of us realize that that is an economic model that is not sustainable. It is not sustainable. So, given the enormity of chronic kidney disease and end-stage kidney disease in the U.S., where do we start? How do we start? How do we get our arms around this enormous clinical problem? It seems simple, but the first place to start is by measuring kidney function. Followed by, once we recognize that a patient has abnormal kidney function, treating the risk factors that have the biggest impact on the progressive nature of chronic kidney disease. And we'll talk about hypertension, diabetes, hyperlipidemia, managing the most important comorbidities in patients with chronic kidney disease, that is anemia and malnutrition, and then providing patient and physician education to support our efforts in prevention and in modality choice for renal replacement therapy. And the way that I look at this is at the top of that schema of chronic kidney disease, stage 1, stage 2 chronic kidney disease, the burden falls on primary care to know and understand the approaches to preventing the progression of chronic kidney disease. And then as kidney function deteriorates and gets into stage 2 and stage 3 and stage 4, that responsibility shifts more towards the nephrologist in order to understand those same effects. And then finally, with end-stage kidney disease, the responsibility shifts more to the nephrologist, working collaboratively with other specialists and primary care physicians. The most important change in the economic model that the government is proposing is one which includes integrated kidney care of primary care physicians, other specialists, and nephrologists together, working to slow down the progression and to prepare patients for end-stage kidney disease when it's necessary. So what about measuring kidney function? That's the place to start. For many decades, we relied on a simple measurement of the creatinine or BUN, often a 24-hour collected urine creatinine clearance, or an equation based on the serum creatinine, the patient's age, body mass, and gender, called the Cockcroft-Gault estimation, to estimate the creatinine clearance. But these are very difficult to get a 24-hour urine collection. I ordered thousands of them on patients, and the worst collections I ever got were from my physician patients who couldn't seem to count 24 hours. About 15 years ago, the modification of diet in renal disease study developed an equation for utilizing the serum creatinine, and other clinical parameters to estimate glomerular filtration rate. And we use that now, since it is reported by almost all clinical laboratories, to calculate the GFR and for us to know whether a patient has stage 1 chronic kidney disease, stage 3, stage 5. Measuring albumin has become an important factor. Measuring albumin in the urine has become an important factor, not only for identifying patients with chronic kidney disease, but as a target for therapy and as a prognostic indicator of progression of chronic kidney disease. So let's now take a deeper dive into some of the factors that we can modify early on in patients that have chronic kidney disease and how we might slow that progression. Again, millions in these numbers. Almost 80 million Americans have hypertension, according to the American Heart Association Statistics Committee, published in 2012. Almost 80,000 Americans have hypertension. It is the most frequent primary care diagnosis seen in the doctor's office. It accounts for 40 million office visits a year, almost 500,000 hospitalizations where hypertension is the primary cause for the hospitalization. And again, billions of dollars, $50 billion in estimated healthcare costs. Over the years, we have seen an evolution of how we define hypertension. I mean, is it 140 over 90? Is it 130 over? Is it different for patients with kidney disease or heart disease? And over the years, I've come to the conclusion that definition of hypertension is not as important as we used to think, because blood pressure is a continuous variable that implies cardiovascular and renal risk at all levels. And that was best demonstrated nearly 20 years ago by George Bacris, who did an early meta-analysis of the impact of blood pressure on the rate of progression of chronic kidney disease. And what he showed is, I mean, what in medicine has a linear relationship with anything? He showed this almost linear relationship from these various studies that he collected from untreated severe hypertension with a mean arterial pressure of 119 or greater, all the way down to what we consider reasonable control or even better control. There's a linear relationship between the rate of decline of glomerular filtration rate and blood pressure. So in your office, you decide, where do you want your patient on this curve? Do you want them losing 2 to 3 milliliters of GFR per minute per year, or do you want them to be losing 7 to 8 milliliters of GFR per year? It doesn't sound like much in a year, but in 5 years, a patient that's losing 6 milliliters a minute, they've lost 30 milliliters of GFR. They've gone from 60 to 30 or 30 to dialysis. So keep that in mind as you address hypertension in patients with kidney disease. The recommendations in both JNC7, published now 15 years ago, and in JNC8, published now 4 years ago, for patients with chronic kidney disease or proteinuria, we should be targeting blood pressures less than 140 over 80, as shown on that slide that I just showed you. Most patients will require 3 or more drugs. If they've got blood pressures greater than 150 over 90, probably best to start with 2 drugs. ACEs and ARBs are the foundation of therapy for patients, many patients with chronic kidney disease, particularly those with diabetics. Don't forget the usefulness of thiazide or loop diuretics in promoting better control with the other drugs thiazides in patients with GFRs greater than 30, maybe loop diuretics for those with less renal function, and any of the other appropriate drugs, beta blockers, calcium channel blockers, they all work to lower blood pressure, and your patients may have other comorbidities that make the choice of one of those other classes of antihypertensive agents most appropriate for that individual patient. Well, how about diabetic nephropathy? Most common cause of kidney disease in the United States, according to the CDC Diabetes Statistic Report from 2017, over 30 million diabetics in the U.S., 1.5 million new cases each year. Do the math. That's 4,000 new cases of diabetes diagnosed every day in the U.S. The most frequent cause of kidney failure, 36.5% of patients with diabetes will have stage 1 to 4 CKD, 52,000 new cases of end-stage kidney disease from diabetes as the primary diagnosis each year. We've known for decades that the control of blood sugars and blood pressures in diabetic patients slow down the progression of chronic kidney disease. The earliest, and one of the earliest, and one of the best studies was United Kingdom Prospective Diabetes Study, the UKPDS, published in a little red journal, the British Medical Journal, in 1998. And here was the UKPDS study. This was a study that was very interesting in its design. They randomized patients to either what was considered at the time tight glucose control or tight blood pressure control. Of course, we would never do that today. We would never randomize them to inferior therapy of blood pressure or glucose, but they were able to do that because the impact of these interventions had not been well established at that time. But you can see that tight blood pressure control and tight glucose control had a positive impact on reducing risk of stroke, any diabetic endpoint, diabetes, death related to diabetes, or microvascular complications. And in the UKPDS study, kidney failure was considered a microvascular complication. So of all of these, the greatest impact was on chronic kidney disease, both tight glucose control, tight blood pressure control. And then a little bit later than the UKPDS study, we began to recognize that the renin-angiotensin-aldosterone system had a major impact on the progression of diabetic kidney disease. And the first and seminal study of ACE inhibitors in preventing the progression of chronic kidney disease, published by Ed Lewis, Larry Hunsinger, and their research group in the New England Journal in 1993, they randomized over 400 type 1 diabetics. They had to have proteinuria greater than 500 milligrams a day and a creatinine less than 2.5. They followed them for up to 4 years, and the randomization was either to the earliest ACE inhibitor, captopril, 3 times a day, or to placebo, and then they equally controlled blood pressures in the two groups with other antihypertensive agents because they recognized that blood pressure control would impact these outcomes, and their endpoint was doubling of the serum creatinine. It always bothers me when I show this slide to summarize 4 years of very hard work in doing this study in one data slide, but in fact, the impact of this study is shown in this slide. For those patients that had creatinines at the start less than 1.5, there was really little impact of treating with an ACE inhibitor. But for those patients that had creatinines between 1.5 and 2.5, the treatment with an ACE inhibitor reduced the rate of doubling of the serum creatinine by nearly 50%. And so this was one of the earliest indications that modifying or blocking the renin-angiotensin-aldosterone system would have a major impact on the progression of chronic kidney disease. And when I'm asked, well, what about these patients that didn't have a severe CKD? Why didn't they show a similar response? I believe that they are the same as these patients, but down at this end of the graph. Once their creatinines get over 1.5, which they inevitably will, they will progress exactly like this group of patients. That matches our clinical experience in the office. That was followed by Barry Brenner's group, which were the first to follow on what we learned about captopril and an ACE inhibitor with the new drugs at the time, the angiotensin receptor antagonists. And they happened to study losartan. They published their work also in New England Journal, not to be outdone by Ed Lewis and Larry Hunsaker. They did a multi-center randomized placebo-controlled clinical trial, but in this time they used 1,500 type 2 diabetics to show that this impact on diabetic-related chronic kidney disease was consistent even in type 2 diabetics. They powered the study for 5 years, but the safety committee halted the study at 3.5 years because they had already shown a positive outcome in the losartan-treated group. And here are those data. There was about a 35% reduction in proteinuria, a 25% reduction in doubling of the serum creatinine, which was one of the primary endpoints of this study, and a 25% reduction in patients developing end-stage kidney disease, which was the other primary endpoint in this study. And this occurred, they were able to achieve these numbers within only 3.5 years of a 5-year study. So the impact of angiotensin receptor antagonism on the progression of chronic kidney disease was well established and has subsequently been shown with other ACE inhibitors and other angiotensin receptor antagonists. Hot off the presses, I want to talk a little bit about the sodium glucose transporter and its impact on chronic kidney disease because we recognize that this is an important target to modify in patients who have diabetes and chronic kidney disease. As I was making this slide, I was thinking of Dr. Lederer, who talks a lot to our fellows and students about transport. So glucose is freely filtered at the glomerulus, but it would be metabolically very inefficient if glucose was lost in the urine. That would be an evolutionary tragedy if we lost glucose in the urine. So we have very vigorous transporters, SGLT2 in the S1 segment of the proximal tubule and SGLT1 in the distal segment of the proximal tubule that respectively reabsorb almost 100% of the filtered load of glucose so that almost no glucose appears normally in the urine. As we all know, there is a tubular maximum for glucose reabsorption, and that in individuals that have very high blood sugars, glucose, that filtered load of glucose will outstrip SGLT2 and SGLT1's ability to reabsorb glucose, and glucose will appear in the urine. Normally, we reabsorb about just under 200 grams of glucose a day. That's a busy kidney. That's a busy tubule. It has been observed that if we block SGLT2 effect and block the reabsorption of filtered glucose in the S1 segment of the proximal tubule, that urinary glucose excretion will increase to 50 to 80 grams a day. And this is a strategy of the SGLT2 inhibitors for treating hyperglycemia in type 2 diabetics. But as part of the evaluation, in fact, in one of the FDA registration trials, the CANVAS program, one of these SGLT2 inhibitors studied in over 10,000 type 2 diabetics, randomized to an SGLT2 inhibitor or placebo, was found primarily in patients with moderate or severe albuminuria to decrease the rate of progression of their chronic kidney disease. Those data are shown here. And you can see that even in patients with normal albumin excretion, there was still an effect of the SGLT2 inhibitor in moderately increased albuminuria. But the greatest effect on reducing the rate of progression of chronic kidney disease was seen in those patients that have the most severely increased albuminuria. These data were published last month in the Journal of the American Society of Nephrology. And last week, the first of the SGLT2 inhibitors was approved by the FDA as a primary treatment for preventing the progression of chronic kidney disease. So hot off the press. So preventing progressive diabetic nephropathy using ACE inhibitors or albumin or angiotensin receptor antagonists to treat albuminuria and hypertension while we monitor albumin excretion, the serum creatinine, and of course the serum potassium level. And now the SGLT2 inhibitors that decrease albuminuria and decrease blood pressure. I'm going to go back to this slide for me because I've been aware of these data for a few years. We knew this a few years ago before this study was published. And I was really skeptical. Why is it that an SGLT2 inhibitor should prevent the progression of diabetic kidney disease? Until I recognized this part of the graph. Notice how GFR declines right away in patients treated with an SGLT2 inhibitor. I don't think we recognized that dip because what we wanted to see was this. So we were blinded to this until we realized this drop in renal function that you see right away and then plateaus is probably related in some way to the decrease in glomerular blood pressure. These drugs decrease glomerular hyperfiltration and they decrease systemic blood pressure. We really don't know the mechanism behind which the SGLT2 inhibitors decrease the rate of progression of chronic kidney disease, but it is now being postulated that it's related to the blood pressure effects and to the effects on hyperfiltration. Okay. What about the relationship between cholesterol and kidney disease? This has been known also for almost 2 decades. I'm going to show you data from the Physicians' Health Study, which was carried out between 1982 and 1996. And even before that, my dad, who is a family physician in a small town in central Illinois, was one of the physicians who participated in one of the arms of the Physicians' Health Study. They also studied the effect of aspirin, low-dose aspirin, on coronary artery disease. So, Henry, this is for you. My dad volunteered to participate. The physicians were randomized to take a placebo or aspirin. And so he got his first box of blinded pills in the mail one day, and he opened them up. He put one in his mouth and bit on it, and it was sweet. So he knew he was in the placebo group. So my dad took a placebo every morning for the next 5 years, and he also took a low-dose aspirin. You can't fool the old-time primary care docs. So the relationship between cholesterol and kidney disease has been known for more than 2 decades or for about 2 decades, this is the relationship between the odds of developing impaired kidney function and the serum cholesterol. So as you can see, as serum cholesterol goes up, the odds of developing chronic kidney disease go up as well. And that's retrospective and it's associative, but Bianchi and his group in Italy published a study that was the first and one of the early studies that I know of that actually showed modifying cholesterol with a statin would have an impact on chronic kidney disease. They took 56 patients with GN, with glomerulonephritis. They had at least a gram of protein in their urine a day. They treated them with an ACE or an ARB for a year before they randomized them to receive a statin or no lipid-lowering therapy. These were primarily patients that had normal cholesterol. And this is what they showed. The statin had an effect on proteinuria. This is the statin-treated group. There was more than a 50% reduction in proteinuria compared to control, and the same was observed in the rate of progression of their serum creatinine after the first year of being treated with an angiotensin receptor blocker or an ACE inhibitor. There was about half the rate of progression in those glomerulonephritis, proteinuric glomerulonephritis patients who were treated with a statin. So I think the recommendation is we should treat hypercholesterolemia aggressively in patients with chronic kidney disease. Interestingly enough, once patients with chronic kidney disease develop end-stage kidney disease and go on dialysis, statins have little impact on their cardiovascular disease. So the time to do these interventions, whether it's treating glucose, treating blood pressure, or treating cholesterol, is early. And that's why I said the burden of this kind of treatment really falls early on our primary care physician. All right. Let's talk about 2 comorbidities that accompany progressive chronic kidney disease. The first is anemia. This is a study, again, from a very large database from the USRDS, the United States Renal Data Systems following study that shows the relationship between anemia at the start of dialysis and mortality from heart disease. Those patients who start dialysis with really severe anemia, they have a much more rapid progression to mortality than those whose anemia has been addressed. How do we approach that? Pretty simple. Characterize the anemia. Not all patients with chronic kidney disease have anemia because of their chronic kidney disease. About half of them are iron deficient. Now, these are patients that have not started dialysis. These are patients who have some level of chronic kidney disease and anemia. About half of them are iron deficient. And so we try a trial of oral iron. We give intravenous iron if necessary by addressing their transferrin saturation, their serum iron, and their ferritin levels. If their hemoglobin drops below 10 grams, then we might give them exogenous erythropoietin at a dose which will help them to avoid transfusions, but never to target hemoglobins greater than 11, because high doses of erythropoietin, particularly in those patients who've had hemoglobins targeted greater than 11, have an increased cardiovascular risk. And coming very soon is the next approach to treating anemia, particularly in patients with chronic kidney disease, the use of the prolyl hydroxylase domain inhibitors. And although those are not available in the United States yet, I wanted to talk a little bit about them and how they work. So when the body senses a normal oxygen tension, hypoxia-inducible factor alpha, which when combined with its sister protein, hypoxia-inducible factor beta, can stimulate gene transcription of erythropoietin. In normal oxygen environment, this protein is prevented from binding to its sister by prolyl hydroxylase. And that prevents a constant stimulation of the bone marrow to make red blood cells. But in situations of low oxygen tension, or in patients that have received this new drug, a prolyl hydroxylase domain inhibitor, if prolyl hydroxylase enzymes do not inactivate HIF alpha, it combines with HIF beta and stimulates or regulates gene transcription of erythropoietin. The PHDIs prevent this from happening, and so encourages gene translation. Now, none of these drugs are yet on the market in the United States, but will shortly. We believe that these drugs will go to the FDA later this year or early next year, and probably will be available by the late part of next year. The reason that I wanted to show this slide is because this mechanism described won the Nobel Prize in Medicine on Monday. So, again, hot off the press. Malnutrition at the start of dialysis is another good predictor of mortality. This is also from the USRDS, from a report by Fritz Port in Kidney International. The causes of protein energy malnutrition in patients with CKD primarily related to inadequate intake caused by anorexia or intercurrent illness, or the unpalatable diets that we used to use in patients with chronic kidney disease. We don't do that anymore. And of course, the catabolic response to many of the inflammatory processes that lead to chronic kidney disease. This is from a wonderful study by Weiner and colleagues. They took a group of dialysis patients, some 2,500 in-center hemodialysis patients with low serum albumins, provided them nutritional supplements during dialysis. The patients are in the clinic 3 times a week. So they gave them a nutritional supplement while they were sitting there on the machine, and they decreased mortality by almost 30%. There's nothing that we do that has a bigger impact on mortality in dialysis patients than providing nutritional supplements. And in fact, this is such important data and such a positive observation that at the company that I work for, we used to provide nutritional supplements to patients with albumins 3.5 or less. We've liberalized that now. Any patient that's got an albumin of 3.8 or less gets nutritional supplements. And we keep them on the nutritional supplements until their albumin is 4 or greater for 3 months in a row. And otherwise, they stay on their nutritional supplements. I've got a little project that we're doing where we're also providing nutritional supplements to patients who are new to dialysis for the first 3 months, regardless of what their albumins are, and to patients who are hospitalized for longer than 3 days, regardless of what their albumins are, because we believe that the impact is so great in decreasing mortality and probably also reducing hospitalization. So, to avoid severe protein restriction, provide adequate dietary energy intake. You can't just give patients with kidney disease protein alone, because if you just give them protein, they'll metabolize the amino acids for calories. So you got to give them 35 kilocalories per kilogram per day in addition to their protein. Supplemental vitamins as needed, and then educate patients and physicians about the importance of nutrition. Use nutritional consults as necessary. Modality choice. There are two decisions that patients make that impact their outcomes tremendously. One is their modality choice for end-stage kidney disease, whether they're on in-center hemodialysis, home dialysis, or transplantation. And the second one is the access that they're going to use if they choose hemodialysis. This is a discussion that is hard for docs to have. I had this discussion many times, and I know it's an uncomfortable discussion to have with patients to say, you have progressive chronic kidney disease, and you are going to need to be on dialysis or need a transplant. This is an admission of failure on our part, and it is hard to have this discussion, but so important. Formal education regarding modality choice doubles the number of patients that go on home therapy or get transplanted. We ask our patients to come to the home training unit to discuss with our nurses the possibilities for home training. And we have developed patient-centered algorithms that help patients decide whether or not they most benefit from home therapy. Said the other key decision is what kind of access. We try to make that decision as early as possible so that we can plan for patients to preserve their veins and to have a permanent access created. No PICC line for patients that have progressive chronic kidney disease. Inserting a PICC line into the arm, that catheter goes up into the central circulation. The vast majority of them will develop some narrowing of their proximal veins and make adequate access impossible. The vascular access type chosen has an impact on mortality. Patients that dialyze with a central venous catheter at the initiation of dialysis have about a 50% greater mortality during the first year than those who start dialysis with a native AV fistula. And it's even worse than a graft. So catheters last. Every patient has an appropriate choice, and that's an individual choice about the access. An 85-year-old or a 90-year-old who is starting dialysis, home dialysis would be much better for them. They probably don't need a native AV fistula that's going to take a year or 6 months to a year to mature. But it has to be a patient-centered approach. We favor native AV fistulas, but grafts and central venous catheters, and always consider a PD catheter as a bridge to transplantation or to home therapy. So I'm going to summarize quickly with this clinical action plan. Patients that have stage 1 chronic kidney disease, we need to be figuring out why they have kidney disease. We need to be treating the comorbidities that I articulated earlier, and we need to be doing things to slow their progression and treat their cardiovascular risks. As renal function decreases, we need to be estimating the rate of progression, discussing treatment options, modality choice, preserving vascular access, and again, aggressively treating their comorbidities. As renal function deteriorates further, we need to evaluate and treat the complications that come with more severe renal dysfunction. Once the GFR falls below 30, we ought to be preparing for renal replacement therapy for those patients that we think are going to survive long enough to require dialysis. And that's also a discussion that I've had many times with patients. It's a good news, bad news thing. The good news is you're going to survive long enough to need dialysis. The bad news is you're going to need dialysis or transplantation. Once the GFR drops below 20, we should be evaluating patients for transplantation. And finally, once GFR drops below 15, we're beginning to make considerations for renal replacement therapy. So finally, apply the specific interventions to slow the progression using control of blood pressure, control of diabetes, lowering cholesterol with a statin, managing the comorbidities of anemia and malnutrition, anemia with EPO and iron, soon prolyl hydroxylase inhibitors, and treating malnutrition. And finally, planning for end-stage kidney disease, smart modality choice, and preservation of vascular access. Once again, it's been an honor and a pleasure to give the Carrasquer lecture. Thank you for your attention.
Thank you, Dave. One other comment that I would like to make to emphasize.
Yeah. Blood pressure, cholesterol, diabetes management, do they have an impact on cardiovascular disease, Henry? Okay. So I think that debating what the right blood pressure is or when to start treatment or whatever is the wrong thinking. I think the right thinking is that blood pressure is a continuous variable that implies risk at all levels. And so we still have to be clinicians that know our patients. So if you've got a very, I hate to use the term elderly because I think I now fit into that. I beg my doctor, please don't write elderly physician in my chart. So I think I had 80-year-old patients who I knew would tolerate very well a lower blood pressure. I had some 80-year-old patients who I knew would not tolerate lower pressures. So my goal was to get their blood pressure as low as I could without causing them side effects of their medication. So falls in patients that are orthostatic or who have low blood pressures because of the medications, falls are a risk factor for our older patients. So I tend to think in terms of the oldest patients and how to prevent them from having adverse events of my treatment of their blood pressure rather than can I get away with a higher blood pressure in a 60-year-old than I can in a 40-year-old. So there's one called Liquicell, which is all protein, has no non-protein calories in it. It tastes awful, but it is inexpensive, and it's the biggest bang for the buck in terms of dollars and protein. But what I do, since we provide nutritional supplements in our dialysis units at DaVita, what I tell our nutritionists, our dietitians in the clinic, if you can find a nutritional supplement that is as good a value as Liquicell but tastes better, get it. We'll pay for it. Because the efficacy of a nutritional supplement that a patient won't take is zero. So they've got to be able to take it. So almost anything will work. And sure, now that I'm older, I use powdered whey protein for myself. Yes. So white coat hypertension is a well-recognized effect in some patients who come in the office and have anxiety about having their blood pressure taken or anxiety about seeing a physician. However, white coat hypertension is not benign. We used to think that if I could get you to take your blood pressure at home and it was normal, I didn't need to treat you. What we know now is that patients with sustained hypertension have a high level of cardiovascular risk. Patients that are normotensive at home and in the doctor's office have a low level of cardiovascular and renal risk. Patients with white coat hypertension have an intermediate risk. So white coat hypertension is a risk. And I'll approach those patients the same way I do my elderly patients. I want their blood pressure as low as I can get it in the office without giving them symptoms at home, symptoms of hypotension at home. So I titrate up. I treat white coat hypertension. I treat it to a point where I don't want them to have hypotensive side effects at home when their blood pressures are going to be lower. But I know they have intermediate level of risk, so we can't ignore it. It's a great, great question. Early information. We don't. Although we have this enormous database, we have over 200,000 patients, and we have tens of thousands of patients who have chronic kidney disease not yet on dialysis that are part of some of our medical groups, and we collect their data. So we end up with millions of patient months of data. So that's something that we might want to look at. We also have a separate arm called DaVita Clinical Research. Dr. Steve Brunelli is the physician lead for that from Harvard and helps us with our clinical analytics. So that's something that we might want to look at. Thank you. Say that again, Peter. I'm sorry. You are preaching to the choir, as you know. Having sat in many meetings with you, you know my leanings in this regard. And that's why, although I may differ politically from our president, that's why that day in July was such a red letter day, because it's the recognition that we have to change the way that healthcare is provided, not just the other things I talked about, but the social determinants of health and the social determinants that drive whether or not these therapies are available, used early on. The failure of transplantation in people of color comes at the very end. all of the steps that happen up to that point, the various social determinants of care. So you're, and the reasons that you articulated are very complex. They're harder to deal with and harder to solve than putting somebody on an angiotensin receptor blocker.
You know, it was an absolutely superb lecture, and you probably never thought you'd get one of these.
I didn't.
But, you know, we give all of our guest speakers, you know, a badge to take home. Your 2019 Gaspar Carrasquer. Congratulations.
Thank you, Eleanor. Thank you all for your attention. Let me turn this off.